If you're watching this video, you probably have been referred to me for cataract evaluation, and you may not know what a cataract is. Well, a cataract is when the natural lens within the eye becomes cloudy. Most people who have a cataract or require cataract surgery are older patients, and the lens has become rigid or hard as well. But sometimes younger patients, even in their 30s, 40s, or 50s, will be sent in for cataract evaluation. And in them, they have an opacity in the lens. The lens is cloudy, but the lens is not really hard yet. The normal aging process in all of us involves the lens within the eye becoming a little thicker every year, a little more stiff, and eventually it becomes opaque. When we're young, our eye is kind of like an autofocus camera, where we can automatically focus at distance and up close just by changing the muscles in our eye so that the lens in the eye will get thicker and thinner to adjust the focus. But once we're over the age of about 40, the lens loses that elasticity, and most people require help with reading glasses to see up close. Cataract surgery is one of the most commonly performed procedures in the United States and in the world. In the United States, insurance generally covers cataract surgery. In the past, you may have heard the term, "Is my cataract ripe?" Well, currently we don't really use that term anymore. What determines whether a cataract needs to be removed or not is whether the cataract is affecting your vision, whether it's impairing your ability to do the things that you want to do. Maybe it's causing you to have trouble driving at night. Maybe you're having trouble seeing colors when you're painting. Maybe you're having trouble reading unless you have really bright light. So all those factors will determine whether the cataract should be removed. In the United States, insurance companies generally have rules about how bad the cataract has to be before they'll pay for its removal. So we take those guidelines into account. We take the patient's symptoms into account before we consider removing the cataract. So we don't really use the term ripe anymore. The other thing that we look at when we're evaluating a patient with cataract is the problem that they're noticing with their vision, are their symptoms entirely from the cataract, or is there another condition in the eye that's also affecting the vision? Well, we want to try and determine that before the surgery so we can counsel the patient on how much visual improvement they might expect. Cataract surgery is a fairly quick procedure, takes about 15 minutes to perform, sometimes less, but the preparation for the surgery is rather extensive. When we remove a cataract, we need to keep in mind that the fixed lens that we put in the eye doesn't act the same way as a young person's lens. So although we can often improve vision dramatically by removing a cataract, we can't restore the eye to its state when it was 20 years old. A young eye has a lens that flexes in and out. But after we take the cataract out, we put a lens in that's fixed. It doesn't flex in and out, but we've got many good lens options now that can give patients distance vision, up close vision, both. They can also correct astigmatism, so we have a lot of options. And I want to spend a little time going over those options because it can be rather complex and confusing. So when we take a cataract out in the past, the traditional lens to use would give distance vision primarily. And that's called a monofocal lens, one focus. And so even today, even though we have many implants that give near vision, intermediate vision, as well as distance, a lot of patients still get a monofocal lens for distance. One advantage is that lens does not cost extra. Insurance covers it. But most patients cannot read or do near work with a monofocal lens set for distance. Now we can also use a monofocal lens and we can set the focus for up close. A lot of times we will do that in patients who have tried monovision with contact lenses. So patients who have tried wearing a contact lens in one eye for distance vision and in the other eye for up close vision, and like the convenience of that, like the fact that they don't have to wear glasses ever, we can do the same thing when we do cataract surgery. We'll often set the dominant eye for distance, and in a right-handed person, the right eye is often the dominant eye. So we might do the right eye for distance and the left eye for up close. The disadvantage of monovision is that the more up close vision we get in the non-dominant eye, the more depth perception we lose. So we don't want to make the two eyes too different, or that will impair depth perception. Now, in addition to monovision, one eye for distance, one eye for up close, with a monofocal lens, we also have monofocal lenses that correct astigmatism. And remember, astigmatism comes from the cornea, the surface of the eye. If it's shaped oval, more like a football, rather than round or spherical like a basketball, that causes blurring in the vision, and that's called astigmatism. So we have monofocal lenses that basically give one focus that also correct astigmatism, and those lenses are called toric lenses. Now, in patients who want both eyes set for distance focus, if they have astigmatism, we could use a monofocal toric lens in each eye. In patients who have tried monovision with contact lenses, where they have one eye set for distance and one eye set for up close, we can use a monofocal lens for each that also has astigmatism correction if necessary. So those would be monofocal toric lenses set at different focuses. Now we have other newer lenses that give us other options. One exciting option is an extended depth of focus lens. So this is similar to a monofocal lens, but it not only would give distance vision, but it gives a focus that comes much closer. So it gives greater range of focus. If we use that lens, we can also offset the two eyes slightly and do a little bit of monovision, and we can get a range of focus with both eyes from distance to up close, where most patients don't need any glasses at all, except maybe for microprint, very close. For example, if you have to read the back of a medicine bottle, you might use some cheaters or some reading glasses for that. Now those extended depth of focus lenses, like the Vivity lens, also come in versions that correct astigmatism. So we can have an extended depth of focus lens that's also toric or corrects astigmatism. Now another great option is a multifocal or a trifocal lens. Now I've been using multifocal lenses since the year 2000, but these lenses have gotten much better over the years. One of the disadvantages of multifocal lenses in the past is that they can cause a little bit of halo around lights at night. So some patients, when they look at a street light or the moon at night, will see a little bit of a halo effect around it with those lenses. And they can also cause a little bit of starburst, which is something that I notice when I wear my contact lenses and I look at car headlights at night. I see little lights coming out of that light, little sharp lights. We call that starburst. Well, these multifocal lenses every few years get better. And we now have a terrific option called the PanOptix trifocal lens that causes very little glare or halo at night and gives terrific distance vision, intermediate vision, and up close for reading. So this lens is terrific for patients who want to have the full range of focus and not use glasses, except rarely for looking really close. When we're thinking about performing a cataract surgery, we need to take into account the patient's pre-existing focus, what they're used to. Are they nearsighted, farsighted? Do they have astigmatism? And then try to figure out what the patient will be most happy with after the surgery. Because it's not as simple as just saying, give me the best lens. Every patient is different. Sometimes we find a patient wants distance vision and intermediate, and they'll wear reading glasses occasionally, or they want everything. They want distance, intermediate, up close, and yet they have some diseases in the eye that preclude them from getting that implant. So certain advanced glaucoma, certain retinal diseases, corneal scarring, it's not reasonable to use one of these advanced premium lenses. They just won't work well in those situations. So when I evaluate your eye, I will look for other ocular conditions that might steer us in one direction or the other as far as our implant choice. Keep in mind that whenever we remove a cataract, we put an implant in. Some people aren't aware of that. Many years ago, patients back in the 60s and 70s would have a cataract removed, no implant put in, and they would have to wear what we called Coke bottle glasses, extremely thick glasses that have a lot of optical aberrations. So we don't do that anymore. Whenever we take a cataract out, we put an implant in. When we are all young, our eye works like an autofocus camera, and it'll focus automatically at distance, in between, up close, whatever we want. Once we're older and our lens becomes stiff, it doesn't focus in and out so well. And when we take the cataract out and put an implant in, the implant is fixed, and we have to decide, do we want an implant that gives one focus, near, far, or everything? When you think about these zones of focus, think about distance as zone 1, far distance vision, the TV across the room. When you're driving, seeing road signs off in the distance, we might call that zone 1, far distance. Zone 2 would be intermediate. So maybe if you're a painter and you have an easel and you have paintings on the easel, or you are a musician and you have music on a stand, maybe out at arm's length, or even a large computer out at distance. Zone 3 is reading vision. So most people would hold a book or a magazine somewhere in this range, and we would consider that to be zone 3 or reading vision. And then zone 4 would be really close vision. Now I'm myopic, nearsighted. I can take my glasses off and I can see in zone 4. That's where my eyes naturally focus. So if I want to read the back of a medicine bottle, I can see that micro print up close, zone 4. Well, we now have lens implants, intraocular lenses, that we put in after we take the cataract out that can give us vision in these different zones. Now, the lenses that we use are different than glasses that are bifocal or trifocal. For example, my glasses are trifocal. On the top of the glasses, I can see distance or zone 1. In the middle, I can see zone 2, and at the bottom, I can read and see zone 3. But I really have to tilt my head a little bit to see through the bottom of the glasses and see up close in zone 3. Well, now we have intraocular lenses that we can put in the eye that give that whole range of focus without having to tilt the head or move. They let you see all those distances simultaneously. But again, it's not quite like being 20 years old where the lens flexes in and out. It just gives vision at distance, in between, and up close. So in summary, when we plan on doing a cataract surgery, we need to take into account the pre-existing status of the eye. Is the eye naturally nearsighted, farsighted, etc.? Are there other ocular conditions that might affect the vision after the surgery? And we need to think about the zones or focus that the patient will most enjoy or use the most. Well, most patients come to me, and I would be the same way, wanting the best vision, wanting it all. Distance vision, intermediate, up close, no glasses, correct the astigmatism. And in many cases that is possible now, where we can use lenses that do all of that, assuming there aren't other ocular conditions that would prevent us from correcting the vision in that way. The thing to know is that These premium lenses cost extra. So insurance companies in the United States only cover a basic monofocal lens and don't pay for these premium lenses, which are often the best choice for many patients. So it's important to think about these options, think about what you're used to, think about what type of focus you want after the surgery and how you use your eyes before we consider whether it's worth paying extra for one of these premium lenses.